Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Thank you to our sponsors, Altum Dental Lab Group and RDT Dental Lab in Toronto. Hello, everyone. Thank you so much for tuning in. We have a fantastic guest today. Her name is Tracey Hendler. She's an orthodontist in Toronto. And we met through a friend who started a group chat between the two of us and said, Tracey and Sanj, you got to meet each other. We're like, well, we're both with women in dentistry. I'm sure we'll meet each other then. And then what happens the night before the Women in Dentistry Symposium? We end up at dinner seated at the same table. And it was so great to get to know you, Tracey.
Yeah.
And that's why I invited you on the pod, because I want you to share everything, like all the common questions about ortho. So welcome, Tracey.
Thank you. And thank you so much for having me. I'm very appreciative to be here. And it was so great to meet you. That mutual friend was absolutely right that we would hit it off. So thank you. Thanks for having
Oh,
me.
you're welcome. And that mutual friend is Sid Lister, who's a chiropractor. So thank you, Sid.
Yeah.
And thank you, Tracey, for being a mentor in dentistry. I know that's what you're passionate about, which is why I invited you onto the podcast. But before I ask you some of the common questions we have for orthodontists, please tell us about yourself.
Thank you for that. Yes, I'm born and raised in Toronto. Educationally, I did a bit of a circle. I did my undergrad at Western. I was actually a psychology major, fun fact. And then I went to U of T for dental school and Rutgers for orthodontics. And I now am like a co-owner of the practice at Forceful Orthodontics, where I was actually a patient as a teenager. So,
Oh, that's such a nice story.
so I'm kind of like right back after all those years and all that travel. I'm basically right back to where I started, which is really nice.
Oh, and you're also a wife and a mom of two daughters,
Yeah.
and that psychology degree and the fact that you're juggling practice ownership and your family. I'm going to give the audience a teaser. We're going to have a part two with Tracey where she talks about work-life balance
Yes.
because I don't know how she does it all. But today we're going to focus on ortho.
Thank you.
So, Tracey, my first question is, when should we refer?
So great question. I think a really good place to start. I guess I'll start with the kind of the party line, which is what the American Association of Orthodontists recommends, which if you're not familiar, if the audience isn't familiar with this is like really something to take home, and it's important. It's kind of 7-up. So the idea is that children around the age of 7 should be screened by an orthodontist. And there is kind of some magic to that number. And the reason is, at that time, kids are going through a lot of developmental change. They should be starting to lose their teeth. They may have habits that need to be broken at that point. And at that point, you can really detect some big jaw discrepancy issues, whether it's AP or transverse or whatever, or crowding. So that's a really good kind of just general guideline. That's for children. Getting older kids, if you don't catch a child at that age, I'd say if you see any kind of like asymmetric exfoliation of teeth, like you should always keep in mind that teeth should fall out within 6 months of their partners. So if the upper canine on one side falls out, you should be looking for a wiggly C on the other side. And if it's not wiggly, that should set off some alarm bells in your head and maybe time to refer to an orthodontist or take a PAM. If you are not treating children and you're looking at, when should you refer adults? Obviously if they have a desire, if adults sometimes want treatment, if their teeth are crowded, they don't like the aesthetics, or they have an uncomfortable bite. And we see a lot of pre-prosthetic patients also. So I think that's really important. I love when dentists send us patients because they want their restorations to last, because they're like, I can do these veneers, but the way your bite is, you're going to just chip them off. So let's get it optimized before restoration. So that's kind of like young to old and maybe some general guidelines to keep in mind.
Now, it's going to be tough to convince a lot of people to take their children to an orthodontist at age 7. So do most orthodontists provide free consultations where we can entice the parents to say, hey, it's a free consult, just go. That doesn't mean they're going to start braces on your kid tomorrow.
Yeah, I think the way that the dentist frames it is so important. Obviously finances, especially right now with the way the economy is
Mhm.
fine for a lot of people. But I think it's firstly, yes, like there are free consultations for children at our office, and I'm sure
Okay.
many orthodontic offices, but it's really the early detection. And in our office, like I can really just speak for myself and the literature, but about 80% of the time when we see kids at that early stage, we're actually not treating them yet. Like they don't
Mm.
need treatment. The studies show that whether you treat them in 2 stages or in 1 stage later on, there's no huge difference. Like they're
Mm.
the same. So we really like to hold off and do it in a more concise phase later on. But parents should know, hey, we're going to send you, it is free. The doctor is just looking for any kind of big issues, and most likely you're not going to need anything yet, right? So they're not thinking that they're going to walk in there and walk out with braces. 80% of the time they're not. So that's good fun to me.
So today I had a patient, 10 years old. There was no room at all for the 1-3, the upper right canine, and the upper left lateral was in crossbite. So I referred him to the orthodontist. Mom's like, well, he's only 10. He has so many baby teeth. I'd rather just wait. And then I said, so what I said to the mom was, well, now you can like create some space, like expand the jaws, and it'll prevent tooth extraction in the future. But then I thought, what if they go to the orthodontist and say, I want an expander because I just kind of alluded to it. And then the orthodontist is like, no, you don't. Let's just wait until you're 12. So am I wrong in suggesting some orthodontic treatment, or should I just, when I give the referral, should I just tell the parent, like, you should just talk to the orthodontist about the cost, the time, the procedures? What do you like to hear from your referring dentist?
Yeah, I mean, I think it's always a bit of a tricky balance, especially if you like don't know what the other person has said or has promised. I think what you said is correct. Like, I think that at some point it sounds like the child will need to have some room made, right? Whether that's now or later. So saying you need some expansion or saying we need to make room for the teeth is appropriate. Then it's up to the orthodontist to say, whether that time is now or whether that time, maybe they'll look if the child's 10 and I don't know how many other primary teeth that patient had, but if they only have a few primary teeth left, maybe they're ready for their comprehensive treatment soon, right?
Mm.
So, or if they have still a ton of baby teeth, maybe like a phase 1 is appropriate. So hopefully the orthodontist would look and say, yeah, you know what, Dr. Sanj is right. There is a lot of crowding here. We're going to need to make space, and based on their bite or their teeth, we're going to need to make space now. Or, you know what, I think they're going to be ready in about a year. So why don't we monitor this for the next, and see in 6 months. And I think within a year, they're going to be ready, right? So I think you can kind of play based off of what you see and what they were told to try to make it all fit together.
Okay, good. So I like how you have the party line, 7 Up, so I can just remember the pop
Yeah.
and try not to confuse it with like Dr. Pepper or like Crush, but say 7 Up. But then there are all these other things we're hearing about airway, myofunctional therapy. There's even like myomunchies for babies. So what do you think of all that?
Now you're asking the tough questions. You're right into it. So I'm going to answer you based on my opinion and also based on evidence, right? And I think that this is like a really hot button topic right now, and I'm sure people listening are going to have all kinds of different opinions.
Yes.
So there is very little evidence, and when I say evidence, I don't mean a clinical trial or the speaker showing cases from their office. I'm talking about randomized controlled trials and systematic reviews and things like that of these appliances. The evidence is very limited and the promises are vast, right? So they're promising everything from reduced bedwetting to better attention to no ADHD to sleeping, like the list goes on. So I would say that based on the limited evidence, I'm really quite skeptical that they can deliver on these promises. I, from what I know of jaw and tooth movement, which is enough, given my training and experience, removable appliances worn for a limited period of time at night, they just don't have the force to deliver, to move the jaws and the teeth in a way that they are promising. I understand that they're being used on younger and younger children. Their jaws are more pliable, but also, I have two children. I have a 6-year-old and an 8-year-old, and I don't understand, quite honestly, how you can get like a 4-year-old to comply with some of these appliances. And then I also think about the like burning the children out, right? If you're asking this of a 4-year-old who has a full primary dentition, I understand the goals and the growing of the jaws and things like that, but I would just ask, like, what are you trying to achieve now that you can't also achieve later when there are some permanent teeth, right? There's only so much expansion you can do with the jaws, and the adult teeth are going to come in, things are going to change again. And then they're going to lose, go through that pause where they don't lose teeth, and then more teeth are going to come in. Everything's going to keep changing. So to keep treating and treating and treating with these appliances that have limited evidence, for me, is not the way to go. Again, I know there'll be some disagreement on that, but I would just like to see evidence that if you waited and treated them at a later stage when they have more permanent teeth, that you can't get to the same point without the added financial burden to the family and the added kind of ask of compliance all those years from the kid.
Totally makes sense. I love that you gave us evidence-based information.
That's
Now, let's go to the other end with treating adults. So, can adults get their palate expanded?
So when you say adults, to be clear, you mean like past 20s, 30s?
Yes. Yeah.
Okay, so what's so great about some of these new appliances or new theories is that it really opens the door for a lot of people to explore orthodontics and get treatment and fix their teeth and their bite, which is great. But I think one thing we have to remember is that people's biology hasn't really changed, right? So if we go back to basics and back to biology, the suture fuses around puberty, right? We all learned that in dental school. So when we talk about rapid palatal expansion, you have to understand that we're aiming to split the suture, okay? What I like to say to patients is, like, we don't know, there's no light that goes off over someone's head and says, okay, now my suture is fused, right? You can kind of tell based on their growth, based on signs of puberty and things like that. But if you're getting to adulthood, you have to use like adjuncts in order to split the suture. You can't just put a rapid palatal expander into an adult and expect to have the same results as you can in a child whose suture is not fused. So what that means is that you could either use something like a TAD supported expander. So that means putting mini screws into the palate, which supports, it's not just putting all the pressure on the teeth, you're also putting pressure on the bones to try to split that suture. And there have been studies that have shown that this can work quite nicely in the early 20s. So just a plain rapid palatal expander, probably not, or not. But with something like a TAD, up into the early mid-20s, that is effective. Past that, the effectiveness really starts to go down. So if you're looking at people late 20s, 30s, 40s, I mean, I'm sure it's been done, but on a routine basis, it's not really predictable. So then you're looking at things like surgically assisted expansion and things like that.
Oh, wow. Well, thank you. And now that we're on the topic of adult ortho, I know a couple of dentists who are in their 40s and they're going through ortho, but it's not clear aligners, it's your traditional brackets. So I said, why don't you go with clear aligners? Because it's, I thought that, at that age, they wouldn't want the metal showing when they smile. And they're like, no, I went to my friend who's an orthodontist and they asked me, do you want it done right? And they said, of course. And their orthodontist friend said, well, then get the traditional brackets, which they did. So what are your thoughts on clear aligners versus brackets? Can clear aligners be used for everything? If you had to get braces right now, what would you get?
Great question. So my teeth are pretty straight. So, and I know some people are gonna be listening to this and some people are gonna be watching it, but if you're not looking at me, you would see that I have quite straight teeth. So for me, if I had some relapse and needed some treatment, I actually think it would be more efficient and more effective to go with clear aligners. And we use clear aligners a lot in our office. Like I actually personally love treating like complex cases with aligners. That includes really the whole gamut. But I understand the limitations and I understand when you have to use adjuncts. So what does that mean? That means that clear aligners are, I think, as good or better at some movements than braces and worse at some movements than braces. So something like an open bite is definitely more favorable to use clear aligners just because the mechanics and the way the plastic interacts with the vertical dimension. But a deep bite in an adult, not great. Like I just had a patient today, actually, 13-year-old boy, class 1, deep bite, tons of spacing, really wants Invisalign. And I told them, like, that is honestly a terrible candidate for bite opening with Invisalign. So I told them, like, if you want a better outcome with your bite, you're going to have to go with braces because all of those factors are going to contribute to his bite getting deeper, which is not going to give him the outcome that he wanted. If he had an open bite, I'd say, yeah, sure. Invisalign, great choice. But I think it really depends on knowing what the bite is, what the challenges will be, really significant rotations, canine rotations, things like that, better with braces, right? So space closure, like extraction spaces, I personally don't like to do with aligners. I'll do some sectional braces and then move to aligners. So there are things you can do to kind of make everybody happy and do, partially with braces, a little bit with aligners and get the result you want, but you really have to know the limitations of both appliances in order to get the best outcome.
So what percentage of your patients are on clear aligners and what percentage have the traditional brackets?
So our practice is probably about 70% children and 30% adults.
Okay.
And overall about 20 to 25% aligners, which includes the adults. So of the kids, we're probably doing, 80 to 90% braces, 10 to 20% aligners. And then adults make up, like, I'd say they're more like 50-50 or 60
Okay.
with the aligners.
And what's the compliance like with the clear aligners?
Very patient dependent.
Okay.
I don't like to like rag on kids and say that like adults are better and more compliant patients. I have some super motivated teenagers who don't want to, like that child who really wanted it today, we'll see what they decide. But, kids who are super motivated are just as effective, great compliant patients, just like adults who are really motivated. So it depends. Like you get the adults who are super aesthetically conscious. They're like, I'm a really big lawyer, and but then they don't wear it because they're like, I'm talking all the time, I'm in meetings, I'm in court, and then they don't wear it, right? So it really depends. Not to harp on lawyers, but it really depends on, I think, the patient's motivation. So I just explain the more you wear it, the better it works. If you don't wear it, it's simply not going to work. And then they can see, if they get to whatever aligner and their teeth aren't moving or they're not tracking, you can tell if they're not wearing.
Okay. And do you ever switch someone and say, hey, your compliance is bad, we're just going to put braces on?
Yeah, I mean, if we're pretty like generous and lenient, I think, we don't rush to switch people. We kind of give them a chance, if people, if let's say they get to the end of their first set of trays or they're not tracking partway through and you're doing a mid-course correction, you say, okay, I know you were having a tough time with this set, let's rescan, let's get you back on track and see if we can, and you have to explain, I don't think we were getting all the wear that we needed. So some of these movements aren't happening as we had hoped. You got to make sure that we're wearing them really, really well with this next set. If they go through the next set and you're still seeing the same thing, you might have a conversation like this may not be the best appliance for you.
Okay. And then how do you deal with those patients who, you lose them? You haven't seen them. They're not coming in for their appointments. And then what's the liability? And what happens when they come back and they're like, I'm not happy with the result?
That's always tricky, and I imagine would be tricky in any area of dentistry. And
yes.
Orthodontics in particular, when there's like active appliances, it's worrisome. We send our patients, we have people in our office who are kind of on top of those recall lists. Like patients haven't been seen, have no appointment for a long period of time. They're sending them letters. I mean, ultimately, if they show up, 2 years later, they haven't been seen, we've probably sent them some sort of like dismissal at that point, usually after
Okay.
a year of no contact. But sometimes we even, it's a year and a half or something like that.
Mhm.
Show up, it usually at that point, unless there's some really extenuating circumstances, we would usually recommend that they terminate treatment.
Okay, that's good.
Yeah.
And then how about for general dentists, especially new dentists who want to get into ortho? What types of simple ortho procedures should we be looking at?
So that's a good question, and it's kind of like a loaded answer. I would say. Um, I in no way want to sound self-serving because
Mhm,
I think that, like any area of dentistry that general dentists want to partake in, like the more you educate yourself, the more you feel comfortable.
mhm,
And I think that's a really great thing. I would also kind of add to that though, that some cases are really deceptively simple. So
mm,
like I'll use the example of someone who is kind of like they have overjet, but it's really minimal and they're really crowded on the bottom.
mhm.
It look like, oh, this is a really simple case. I'm just going to do this with aligners. But if you miss that they're then going to be edge to edge at the end, then you could really negatively impact their bite. So I would just say, like, if you're going to be doing any area of dentistry, kind of at these more, let's say, advanced levels, you just have to be prepared to undertake the whole case and really understand what the outcome would be and how to deal with kind of complications along the way.
Okay.
So
So do you think it do you think it'd be appropriate for example, someone has a habit like thumb sucking, tongue thrust, where we do the habit breaker, or they have a cross bite, we open up the bite and put a removable appliance to align the teeth. Are those some things that general dentists can start doing?
Yeah, I think that's a nice
Mhm.
sort of patients. You have a relationship with them, and certainly, I mean, habits are I prefer if that was caught earlier and stopped earlier. I usually see ourselves as like the last resort on those cases, uh,
Yeah.
because the patient really has to be motivated to stop, and if they can stop it earlier and more simply, then I think that's a great thing.
Okay, good. And then how do you deal with those patient expectations? They're looking at their phone on their selfie, zooming in. They're like, can you just rotate that 1 degree more? Like, how do you respond to that?
Is it the fourth refinement or like what
I
refinement?
know, exactly.
What refinement
How
are
do you even have patience? Is that how many refinements people are asking for?
well, the people you're mentioning? That's, I it depends. Like I would say that I really always try to see what they're seeing.
Okay.
I will like legitimately try to see if they are bringing out their phone and they're like, this tooth is rotated. I will really look and try to see the rotation. And I would say if I can see the rotation, then I'll try to fix it to the point that they're happy. If, I simply cannot see what they're seeing and we've kind of gone through everything and it's as good as I possibly think it can be, then at a certain point I say, this is, I think, as far as we can go.
I'm laughing at, if I can see what they can see because yeah, so many times I'm like, I don't get it.
Yeah.
What is it that you're looking at?
I mean, sometimes it's like, so we hear all kinds of things like when I feel it with my tongue or when I rub it with my finger, like you can't see it, but I can feel it with my tongue. And it could be that like the labial surface is aligned, but the tooth is a little bit thicker on the lingual. So they
Oh, okay.
feel it with their tongue, right? Or, you know, something on the labial as well. So it's a tooth shape thing, right? Like it might be totally straight, but if let's say the edge of a tooth is a little bit more tapered, it doesn't look like they think it should look. And then we say, I think you need to go to your dentist and have that bonded so that it looks ideal.
Okay.
Yeah, it's a tricky one. What?
And like I heard orthodontists will see, like 70, 100 patients a day. They're just going from chair to chair. Like, how do you manage that? How do you even write the notes for all those patients? At the end of the day, like, you must be white. So tell us how you do it, Tracey.
That's I've been doing this for 12 years now. So I would say I had a lot more what I would call like decision fatigue at the beginning. I would be constantly second guessing and should I put a power chain on that patient? And did I tell them to wear the right elastics? I was kind of constantly second guessing what I was doing, and all those decisions over the day really wore on me. I think at this point, I guess I hit my stride in that respect, that the volume of patients we see feels kind of second nature to me. Our office also is like, we have a lot of team members, we have a lot of staff, and our team is highly trained and we trust them. So we do a lot of, delegation, in our office where all the doctors are very picky. So we do, all the positions and all the bends in the wires and all those things. But we do trust our staff to like take the wires in and out, and we do dictate the notes to them, they write them. So if there's ever like a long conversation with a patient, I will double check it and make my own notes. But if it's something more routine, then I can see the notes being done chairside and I know that they're accurate. So it takes a load off.
Okay, that's good. And then how do you deal with the stress?
The stress of the
Yeah, the time management, patient expectations, dealing with the large staff that you have to make sure that are doing their job. And then just like dentistry is stressful, like just figuring out like what your ortho treatment plan should be, how to bend the wire. I remember that was the most stressful thing during dental school, is that how to, because we had to see two patients from beginning to end when I went through dental school at Toronto.
Yeah.
And it took me an hour to figure out how to bend a wire. So how are you managing with the stress?
Yeah, I mean, I guess we all have our good days and bad days, right? Like I would be lying if I said that, oh, I just have it all under control. Like
Yeah.
that's obviously, not the case. I'd say most days I handle the stress pretty well, but there's certain triggers or patients or conversations that you have throughout the day that, kind of push your buttons and cause that blood pressure to rise. I do have a partner, so I work with a partner, Bruno Venditelli, and I think having a partner and, we have an associate, Nessa Chong, and I think having other orthodontists here with me, to bounce ideas off of or share the load is really helpful. So it's not like I feel like the entire stress of everything is on me. I would say that in dentistry, you have to kind of keep going, right? Like I'll compare it to general dentistry. If you have like a really difficult extraction or a really difficult conversation, or your crown doesn't fit or something with one patient, you still have to move on. You still have hygienists calling you for the hygiene checks, and you have to go see another patient. So no matter what happens with one patient, you kind of have to pull yourself together and keep going, I find. So I don't know if it's like for better or for worse. There's, a whole bunch of other people waiting for you, and it's not fair to like take out your stress on them. So I just feel like you have to I guess pull yourself together and internalize the stress, at least for the time being, and not make the rest of the day suffer because of what just happened, and just keep going, and then kind of deal with and process whatever you have to deal with when it's quiet, whether that's between patients or at lunch or at the end of the day. So I don't know.
Okay.
That's how I do it.
Oh, good.
I internalize the stress.
And have you ever seen anyone do DIY ortho? Like there was this case I saw on the internet where, a young boy tried to close the diastema himself with elastics, and the
Yeah.
elastics moved apically and ended up avulsing his two upper centrals.
Yeah.
Have you seen any DIY ortho?
Thank goodness, not in real life.
Okay, good.
I've seen it online, and I mean, we don't have to get into the whole direct to consumer aligner business,
Yes.
things like that. But this orthodontics in any area of dentistry it has real consequences and real like side effects, right? If it's
Yeah.
not managed properly. So just like I don't think anyone should be doing their own open heart surgery or biopsies of their skin, like I think that these things need to be managed by healthcare professionals. and monitored properly. And thankfully, I have not seen anyone. I've seen people come from direct aligner companies with kind of adverse outcomes that we've had to.
Oh, that's too bad.
Not anyone who's like done their own elastics or anything like that.
Okay. When I was a kid, I used to take paper clips and bend them to make it look like retainers and put them over my teeth.
Yeah. Same.
Yeah.
I thought it would make me look older and cooler.
Meanwhile, everyone's like, why do you have a paper clip in your mouth?
Yeah. That was so cool.
That's so cute. You were destined to be an orthodontist.
Yeah, exactly. We were destined for dentistry.
So, do you have any resources or courses that you'd recommend for dentists who want to start doing some ortho in their office or even want to become orthodontists?
I can't speak to specific courses. I've seen a whole bunch being, the names being thrown out online on various forums. I haven't taken any of them, so I can't.
Okay.
The ones that are being recommended. I've taken a whole lot of CE, but it's been geared towards orthodontists.
Okay.
So I can't speak to that, but yeah, I mean, I think there are courses out there that I'm aware of.
Yeah.
I think, something that's a little bit more holistic and comprehensive is going to be better than something that's like, in one weekend, you're going to learn how to do, in the morning, we're going to do class 2, in the afternoon, we're going to do class 3 in surgical cases, and tomorrow we're going to do extractions, and in the afternoon, we're going to do liners, and then you're done. Not really possible to master.
Okay.
Time. So just be aware that if, like anything, if you're going to, be undertaking this type of treatment, to really put in the time and get educated on the proper way to treat patients.
Well, thank you, Tracey. If anyone has any questions for you, how can they get a hold of you?
I am very accessible. You can email me, and I can provide Sandra with my email address that you guys can email me and ask questions. I also am online. We're at Forest Hill Ortho, or you can visit our website, Forest Hill Ortho.
Oh, great. Thank you, Tracey. And I'm looking forward to our next podcast later this year where we will be talking about work-life balance. Thank you so much, Tracey.
Thank you for having me. Thank you so much. I look forward to it, and I'll have to figure out a better way to internalize my stress and have a better answer for next week.
See, it's a teaser. Stay tuned. Thank you. And thank you, everyone, for listening. This podcast is sponsored by RDT Dental Laboratory, your full-service dental lab in Toronto. RDT Dental Lab will help you grow your practice through education, predictable restorations, and high attention to your clinical needs and patient experience. Check them out at rdtdentallab.com. Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.